Hello, everyone. My name is Virginia Volpe. I am a Hematology Oncology Fellow at Moffitt Cancer Center in Tampa, Florida. I am discussing with you today the relationship between SF3B1 somatic mutation and therapy-related MDS. Over the recent years, there has been an increased interest in further defining and investigating therapy-related myeloid neoplasms. In our center, we evaluated the outcomes of patients with SF3B1 mutation between therapy-related MDS and de novo MDS. We then further evaluated the outcome among therapy-related MDS in patients harboring SF3B1 mutation versus those with SF3B1 wild type. We've recorded and analyzed baseline characteristics such as CPC with differential, bone marrow blasts, WHO classification, cytogenetics, RIPSS category, and AML transformation. When we evaluated the SF3B1 mutant in de novo versus therapy-related MDS, both groups are fairly similar. However, therapy-related MDS patients were older in age and had more high-risk karyotype. There was no difference in AML transformation between the two groups, and besides Sybil somatic mutation, which was more frequently seen in SF3B1 mutant therapy-related MDS, somatic mutation distribution was not significantly different between the two groups. Overall survival was significantly better in de novo SF3B1 mutant MDS than SF3B1 mutant and therapy-related MDS, with 103 months versus 59 months respectively. We did adjust for the comorbidities using Charlson Comorbidity Index, which did still show worse survival with a hazard ratio of 2.1 in therapy-related MDS compared to de novo MDS. Next, we evaluated SF3B1 mutant to SF3B1 wild type in therapy-related MDS patients. Here, the groups are more contrasting. There were higher bone marrow blast percentage, lower platelet count, more complex subgenetics, RIPSS high, very high category, and more AML transformation with SF3B1 wild type therapy-related MDS than with SF3B1 mutant therapy-related MDS. These demonstrated statistical significance. Mutational distribution revealed statistically significantly higher TP53 mutation in SF3B1 wild type therapy-related MDS compared to SF3B1 mutant therapy-related MDS. Overall survival was also significantly worse with SF3B1 wild type compared to SF3B1 mutant in therapy-related MDS with 17 months versus 43 months respectively. In concluding our study, SF3B1 mutant are more common in de novo MDS than in therapy-related MDS. De novo MDS SF3B1 mutant had better outcomes compared to therapy-related MDS SF3B1 mutant, although baseline characteristics and rate of AML transformation were similar amongst both. Even when adjusting for comorbidities, those with therapy-related MDS still had a significantly worse survival, which may suggest potential lasting effects of prior malignancy treatment playing a role. However, this does still need further investigation. In patients with therapy-related MDS, those with SF3B1 mutant behaved more indolent and had better outcome than those with SF3B1 wild type in therapy-related MDS. Complex subgenetics, TP53 mutation, and transformation to AML occurred more frequently with SF3B1 wild type than with SF3B1 mutant in therapy-related MDS. In therapy-related MDS, SF3B1 mutant may portend a better prognosis, and it behaved closer to de novo MDS with SF3B1 mutant. There is a difference between this and the literature regarding the prognosis and outcome of therapy-related MDS. In the future, the diagnosis of therapy-related MDS may benefit from redefinition to not only include clinical phenotype, but also a molecular phenotype. Thank you for the MDS Hub for inviting me to speak on behalf of SF3B1 mutation in the context of therapy-related MDS.